Yeah, good morning to all of you. On the last day of the conference, thank you for assembling here for this one. The session is Double Trouble in Cataract Surgery. We are covering scenarios where there can be different kind of problems in the same situation or in single case. So you can have a multiple of problems. You can have a problem like glaucoma associated with cataract or something like that. So here we have three different scenarios. One is cataract surgery in the setting of glaucoma, and then some retina cases which are complicated with another issue, and then cornea related issue along with some other thing. So we have 7 speakers for today. Let us just straight away go into the talk. I request Dr. Mallikarjun Hiralgi. He's talking about cataract surgery in pterygium. So how to deal with a scenario where we have 2 different scenarios like that. Dr. Mallikarjun.
Good morning all.
4 minutes.
I'll be talking on cataract surgery in pterygium. And it's a very simple condition, but is a very often very difficult to manage, because most of the patients in our day-to-day practice, many patients will come with pterygium in different type of pterygiums and with different socio-economical background and different expectations and all. So sometimes it will becomes difficult to decide how to go about it. So whenever I see a cataract patient with pterygium, I think of 3 options in the management: whether to do a cataract surgery only, or a sequential surgery, do a pterygium excision first and then go for a cataract surgery, or a combined surgery together. So these are the possible ways how you can manage. And I have made a very simple strategy which is working well for me, and I do only cataract surgery when the pterygium is very small and the astigmatism is less than 1.5, and atrophic pterygiums, and which are non-progressive, which we have not, if you have seen them, if they have come to you for a regular follow-up, and you have seen that it's not progressive, for them I do only cataract surgery. And some patients will not be bothered for cosmetically, because I have a place where I work, I get all sorts of patients, like poor patients, rich patients, and some patients they'll have very high expectations also. So depending on, I decide. And also I make sure that I counsel them, they might require a pterygium surgery later. Even they have undergone only cataract, they might require a cataract later. And when I do sequential surgery, if the pterygium is more than 1.5 diameter of astigmatism, and a progressive pterygium, big pterygium, and of course pterygium which are nearing to the people, young patients, they have a tendency to progress the pterygium. For them, I do a sequential surgery. And double head pterygium. These patients also we see in many patients, they come from rural area, and many patients will have the double head pterygium. There I do a sequential surgery. And this is one case, very irregular cornea, if you see there. And although pterygium is not very near to the people, it is causing a lot of irregularity and more astigmatism, and a lot of higher order aberration patient has. So such patients I prefer to do a sequential surgery. For doing a sequential surgery after pterygium excision, at least we have to wait for 3 months. And if you have done a larger pterygium excision, you have to wait for longer time, because it takes a very long time to stabilize. And if you have access to the topography, better to do a preoperative and postoperative topography and assess the astigmatism part, and also you have option, you can assess the higher order aberration. The end point is stable astigmatism. Stable astigmatism, not the keratometric value. The patient what astigmatism he accepts. That is the endpoint that you have to take. Because these keratometric values might change later, but whatever the patient accepts, that you have to take in consideration and decide. And few tips for doing a cataract surgery after doing a pterygium excision. I do monofocal if the IOL astigmatism is less than 1 point diopter of astigmatism. If the astigmatism is more than 1.5 diopter of astigmatism, then I plan for a toric IOL. If you're planning for toric IOL, you have to wait for a long time. And the aberrations and astigmatism, as I said earlier, should be stable because patient will be unsatisfactory. Of course, for the reason of the pterygium excision scars and pterygium into dry eyes, and even if you have done a good pterygium, they will have a higher order aberrations. So better to avoid this premium IOLs like multifocals and trifocals in these patients because they will not be happy. When I do combined surgery, if the astigmatism is less than 1.5 diopter of astigmatism, small but progressive pterygium. If your patient has been coming to you for follow-up, if it is progressing, I plan for combined surgery. And patients with mature cataract, I'll go ahead with combined. And the patients are cosmetically bothered and they don't want 2 surgeries. Some patients, they tell, I don't want to undergo 2 patients, then such patients I do a combined surgery. What pterygium does is, it flattens the cornea in same axis. And after we remove the pterygium, it steepens there. So when you're doing combined surgery, you have to reduce the IOL power by 0.5 to 1 diopters. That would compensate for the change in the cornea. Some tips, all of you know, excision with conjunctival autograft is the surgery of choice for pterygium surgery. And you can either use fibrin glue or patient's own blood. And always you have to dissect at the level of the pterygium and don't dissect more deeply. That would cause more scarring and also healing takes longer time. So it's something you should aim for like this. So this is the graft and cornea looks clear here. It is often not possible in all cases, but as much as possible you have to try to make the cornea like this. And you have to explain to the patient that recurrence is possible. So if the recurrence is there, then again we'll have to go for surgery. And you have to remember, even if you have done a good excision and cornea looks clear, they will have a little bit higher order aberrations. So good counseling is very important in these patients. Thank you now for the discussion.
Thank you, Malik. It was a wonderful presentation. I have one question for Dr. Sudhir. Sudhir is a senior consultant to cornea refractive surgery at Shankar Netralaya. He's an excellent surgeon. So what is your indication for combined procedure, combined phaco with the pterygium, and when you want to do it sequentially, and how long you will wait?
Yeah, I agree with Dr. Mallikarjun. I think he has summarized it very well. Because when you're looking at refractive outcomes in all the cataract surgeries, I think pterygium is only basically a cosmetic, and for refractive, I think we have to be very careful. If the astigmatism, we go much further, like even less than 1. If there is astigmatism, because we screen all the patient with keratometry, and if the keratometry shows astigmatism, absolutely we counsel the patient not to go ahead with the combined surgery, have a sequential. And I burned my fingers initial days when I did a toric IOL. The patient came from military and he wants XX vision. He had a pterygium surgery done elsewhere. It was 1.5 months. He didn't tell me, he told me it's 3 months. So then I had no choice to go ahead with the toric IOL. We were so happy with 6/6 vision at glass appointment, but he came back after 3 months with a residual astigmatism back. So it is very important that we have to wait minimum 3 to 4 months. Like what we do, the scar modulation occurs until at least 4 to 6 months. So, but if the cataract is very dense, then we have to go ahead and tell the patient and counsel. 3 months is a minimum thing for the scar modulation. Otherwise, you have summarized all the points well.
There is one new paper which has come up. The authors, they do anti-segment OCT to know the depth of this pterygium, and if it is deep, if it has penetrated the cornea beyond Bowman's, so there is a chance of wound modulation for a longer duration, which can go up to 6 months. So, like, I think if you have a tool like anti-segment OCT, it's better you do a OCT and see the depth of this pterygium, and then plan your surgery accordingly.
It's a very good point,
that's
but
also
everybody
not
won't have
only-
access.
Yes, sir.
Everybody won't have access to anti-segment
Yes, you
OCT.
have an access.
Sir, even if you have a Scheimpflug camera,
Yeah.
Scheimpflug camera also can give a little bit information of the depth of the pterygium. Even Scheimpflug camera, the image also can give.
So another thing about astigmatism, surgically induced, since I'm in a government institute, we are carrying out research all the time to look for the reduction of surgically induced astigmatism. And we talk about on-axis incisions and all that. So is it possible in regressive pterygium to, to neutralize by your site of incision for the surgery? Site of corneal incision.
Corneal incision.
Yes.
So if you are doing a clear corneal incision, if you are doing less than 3 millimeter, you are quite clear.
So we still find 0.5 to 0.75 is still there. And now the latest candidate has been given as research, endothelial cell loss between SICS and phaco to put money where our mouth is. But I was just interested if you had studied the SI, the surgically induced, if there was any change post-operative.
No, you can go and you can go ahead with the dose. You are doing SICS. Go put a section at the steeper meridian.
Exactly.
So
yes.
that would reduce
It
at
helps
least about,
in these patients
Yeah.
because we did a study on pterygium with the supratemporal area for harvesting the autograft. It gave good results, but long term there was some recurrence. So I just worried, but it was very nice.
So nowadays what I am doing, I don't take the graft from the superior area. I take in the inferior area.
Astigmatism will also change.
So
You want
in
to
that,
preserve it for
preserve for
future,
the cataract surgery, and also if the patient, in case many glaucoma specialists are there, they would agree with me. In case patient needs further surgery of some blebs, then
filtering
you can
surgery, yeah. Doctor, you mean to say you want to put incision superiorly for all the cases? Because you end up having visceral astigmatism in pterygium.
Yes, sir.
You put
So,
superior incision
with
for
the
all the
rule
cases.
superior, with the rule superior. Sir, I'm head of glaucoma in the institution, so I like to save the site for future.
I know.
The little stingy about that.
Pterygium may grow subsequently and the amount of
Recurrence.
astigmatism can vary. So if you are correcting astigmatism due to pterygium by incision, subsequently over the time it may change.
Because
No, so my other concern
it's been proved that your surgically induced astigmatism is just 0.1 diopter. Even the centroid studies have shown that it's just 0.1 diopters. By placing the incision on axis, it hardly corrects your astigmatism by 0.1 to 0.2 diopters. So for that, I don't think.
About SICS and
SICS,
plus I'm
you
talking
meant-
about the combined surgery. Even the pterygium post-operative, you say the steepening will take place. That will also take place over time. So
Over
again
time,
there
yeah.
will be.
Compensation. Yeah.
Can we move on to the
Next topic.
next talk? The next talk is living in a shallow AC hub. Dr. Monica Chetan. Dr. Monica Chetan is glaucoma consultant at Netradama Eye Hospital at Mysore.
Dr. Rajesh Sinha's talk, should we take or what?
Good morning, everyone. Thank you, AIOC, for giving this opportunity. The double trouble I'll be talking about would be one of the trouble is the cataract, and the second is operating in a shallow anterior chamber. For the time constraint, I made into an audio-visual play. Can we have it, please?
Living in the shallow AC hub, the lessons my cataract cases have taught me. A safe surgery involves a proper pre-operative evaluation and preparation of the patient. Please give adequate importance to a good slit lamp examination, especially if attempts of PI has been made at multiple sites. A quick glance of the biometry is also important. On the day of the surgery, take care that the intraocular pressure is well maintained. One can be liberal with local anesthesia depending on the patient's cooperation and the eye condition. A vitreous dehydrating agent like mannitol and Bristol can also be used to reduce the thrust. And finally, anticipate the difficulties that you can face at each step and modify each step accordingly for a safe surgery. My surgical approach to phaco in shallow AC. The sideport incisions have to be slightly inside the limbus and longer and parallel to the iris plane. Do not touch the iris or the capsule. In case of shallowing of AC during incision making, reform with BSS or visco. The main root should be also slightly inside the limbus and longer than normal. Do a proper aqueous replacement with a good viscoelastic to deepen the AC before making an adequate size of CCC. After CCC, it's important to burp the wound and decompress the AC before any hydro procedures. A gentle hydrodissection with as little fluid as possible is important, with subsequent decompression to release the trapped fluid. This prevents the rise in intracapsular pressure and prevents further AC shallowing and iris prolapse. During nucleus handling, we have to remember that such cases may be associated with high lens thickness or zonule laxity. So in shallow AC, it is essential to do chopping in the back and making as many small pieces as possible. Emulsification should be at the rhexis plane. Avoid any supracapsular method of phacoemulsification and anticipate zonular defects or weaknesses, especially at the site of. Once you remove a 4 to 5 mm lens, space issue is resolved to a great extent. Cortex removal and IOL implantation will be as routine in most cases, except sometimes you can face a few rare incidences. A case of shallow anterior chamber post-PI, thrust was felt during phacoemulsification. After cortex removal, a purple-blue glow was seen in the vitreous cavity with thrust. This is probably due to the fluid and dye going into the vitreous cavity through lax zonules or PI. A few precautions that have to be taken during surgery. Iris can be your best friend or your worst enemy. Do not irritate it. This is one of my old cases showing the probe touching the iris during trenching and causing an intraoperative miosis. Even if it happens, be careful and be prepared with intracameral adrenaline or pupil expander devices. Probably the most common issue we face during phacoemulsification in such cases is iris prolapse. It occurs due to the trapped viscoelastic or fluid below the iris. If you try to deposit it back with the probe like it's happening in this case, it will cause more prolapse of the iris. So do not go in with the phaco probe. Do not try to reposit the iris injecting viscoelastic from the same site. The ideal way to do it is pull the prolapsed iris in from a different incision and decompress it to release the trapped fluid or viscoelastic. Tamponade the iris with a little viscoelastic also from the main site. So in conclusion, I would say that phacoemulsification in shallow AC involves keeping friendship with and respecting the iris, maintaining an equal distance from the endothelium and the posterior capsule. Thank you. Living in the shallow AC hub, the lessons my cataract cases have taught me. A safe surgery involves a proper...
Thank you so much. It was a very nice one. I didn't know you could cover so many things in such a short time. I think, Dr. Manisha, any comments you? Yeah, she's waiting.
Because shallow AC, so that is in the huge area of interest. And you said PI and all that. So are they in angle closure glaucoma cases?
Yes, ma'am.
They are angle closure
Especially
glaucoma.
stay in Mysore where I face a lot of angle closure cases.
Yes, exactly.
So that's why I was
and I
emphasizing.
saw advanced cataract also.
Yes.
So wouldn't you like to go for, what I do is I go for a combined surgery in these patients, because even post-operative intraocular pressure fluctuates, and we know the fluctuation is really bad for the optic nerve head, right?
Yes, ma'am.
So is there any reason you're not doing a combined surgery
No, I
in
didn't
these?
put one of those. I put one in which the cataract was done. But of course, many a times when you saw in the biometry picture here, the lens thickness was around 5.2.
Correct.
AC depth was around 2.0.
Yes.
Makes all the sense to combine
Combine.
both and do it.
And the
because
other
after replacing a thicker lens which is thinner one and making more space for the fluid to pass.
Exactly.
I didn't put one of those videos. This was just a pure cataract, but I do take your point, ma'am.
And the other thing is that being a glaucoma surgeon, I'm sure you're doing glaucoma surgery, aren't we stingy about keeping a space for the blood for future
Of
glaucoma
course, ma'am.
surgery? No?
Always,
So then we
always.
have actually made a side port and the incision. So I don't know, I would go for a combined surgery, right?
This case was not actually a glaucoma case. Like these are
Okay,
some.
you said PI, no, in all the patients.
Ma'am, that was just to prepare if any patient with shallow ACs are there, any other case. This was not specifically a glaucoma case. Otherwise, of course, ma'am, the handling of the conjunctiva, irrespective of whether actually he has glaucoma today or he develops tomorrow, we don't know. We have to give respect to the tissue.
Thank you.
But in a lens thickness which is high, won't it be better to do the cataract surgery alone first to see what's the post-op response in terms of IOP control and then plan for a combined
So this we
procedure?
used to do several years ago. Then I realized that our patients, I have a large series on that 50 plus club. They come at undiagnosed glaucoma, advanced. So both eyes, swollen lens, mature cataract, you cannot even evaluate the optic nerve head. And the pressure is above 50, they're unaware. So in these cases, I do a W trabeculectomy. And if they can afford an Ologen implant, I do an Ologen implant. I have a series over several years of 90 patients. So they respond, that's the only surgery because you make such a big window that they respond to that and advanced cataract already when they...
No, I was just talking about the advanced cataract with the thick lens.
So the
wherein if
pressure fluctuation post-operatively, few of them turn out to be steroid responders also. So whatever is left of the optic nerve head is further damaged because the evaluation is very difficult in these cases with mature cataract of what the state of optic nerve head is.
You can take care of pressure by putting drops, no?
No, sir, but post-operatively,
Yeah,
there is a
Please go ahead.
fluctuation, large fluctuation.
Because as such narrow angle closure glaucomas, just even people have done clear lens extraction also to create the space.
If the angle is, it's just apposition
I
closure,
think,
not synechial closure.
Sir, it will depend also on the gonioscope.
Yeah, once it's synechial, then there's no point. The idea is just to take care of the appositional, to reduce the thickness of whatever is there so that the iris falls back. That's the basic idea.
Although we are glaucoma surgeons, we're just not trigger happy. We try, if this patient will respond without the combined surgery.
Maybe glaucoma surgeons are more biased towards doing trabeculectomy.
Come in here.
Blanket rule of doing grabs for, because if the optic nerve head is looking healthy, just for shallow
We
AC.
can't see it. I'm talking only about these cases.
No. This was not a
I think-
glaucoma case, sir.
I think decision
the
should be
three-
based on gonioscopy.
I think the 3 points would be the IOP and the gonioscopy.
And the optic
If you do not have pass for more than 2/3, then it doesn't make sense to go for trabeculectomy. I think the message is taken little different. This was not a glaucoma. It was like shallow AC. So I think the 3 points are the IOP, the gonioscopy, and the optic nerve head. Otherwise, there's no sense to do both together. No.
And
That's
just
a-
one point I would like to add that in such shallow chambers, the main incision I would like to put a little anterior so that the risk of iris prolapse in the post-op, in the intra-op period is less.
It's very troubling that iris prolapse.
Coming one.
Yeah, I think for the iris prolapse, I think one thing which works out very well is using a viscoat like things. No, it actually goes to the angle and keeps it the iris well away. So I liberally use viscoat multiple times, and it really gives.
I think-
One thing is the chamber is narrow, small, so the endothelium gets well coated, angle is well protected, iris doesn't come out. So using it is very, very important.
Is Orocoat, sir. Works wonderfully well because it helps all the 3 parameters together and it won't come out as a full bolus. So I think that's a good thing.
IV mannitol, has anybody given IV mannitol intraoperatively?
She's preoperative.
Only if the pressure is high,
Pre-op.
then only, pre-op only, but only if the pressure is high. Otherwise,
Again, the gonio findings, the lens thickness, the pressure, what you're anticipating from the patient, all that has to be taken into account.
And other thing, probably we have to keep in mind in these patients is very shallow AC, might require some vitrectomy as well.
I think that will be covered by Dr. Mithun Pai because I showed one fluid misdirection. He has that case only. So he'll be showing that.
Dr. Suresh, would
Suresh.
you prefer to do a PI in this patient because if there is
If
positional closure in that?
I feel quite a lot of things go based on the confidence of the surgeon in handling a shallow AC. Because once a patient of shallow AC is operated, more likely than not, the AC is going to deepen. So, yeah, if I think you can confidently manage a shallow AC, you can just, in fact, you can use it as a treatment even for primary angle closures. Regarding the decision of doing a trab or not, it is based on so many other factors. Just having a shallow AC will not be a factor in taking a decision whether you want to combine trab. So another is chronicity of the situation. If at all in the intraocular pressure is high and the case has been very chronic, and if you have evidence that there is some significant damage to the optic nerve, these would rather bias you towards taking a decision whether you want to include trab.
Yeah, it has to be case-based actually.
Yeah, case-based. Yeah, please go ahead. Last question I think we'll take and go ahead. Yeah.
Precautious use of Trypan Blue is very, very important because few cases shallow AC, if you put too much of Trypan Blue, it can hydrate the vitreous, there will be too much of pressure. Again, intraocular hardening can makes the shallow AC surgery difficult. So just go to the simple one drop of Trypan Blue and move on to correct it.
Yeah, I think even again that would be convenience and based on the type of cataract, whether it's mature, immature. Of course, yeah. One thing in your favor would be using Trypan Blue makes the capsule more friable and more easy to it. But on the flip side, you can also see that, you know, if there is a shallow AC and if in case there is bowing of the lens anteriorly, then it may also cause more easy runoff as well. But yes, visibility definitely gets enhanced significantly.
I meant to say, Trypan Blue, we usually we inject it rather than injecting because Trypan Blue is known to hydrate the vitreous and it can make the intraoperatively the hard eye.
Vitreous?
No, actually, what I could figure out is that these things do happen when you have a case which is operated in a vitrectomized eye, wherein there is some zonal deficiency, wherein you have the chance of aqueous misdirection, wherein if you inject Trypan Blue excessively, then it will go posteriorly. I mean, that is what you meant, no?
Sir, I think you are meaning aqueous misdirection syndrome when you are irrigating. It's not because of Trypan Blue.
Sometimes aged people, there can be zonus laxity where too much of Trypan can go into the vitreous and hydrate.
Why too much?
Any fluid, if it goes into vitreous, it will hydrate. It need not be only Trypan. It can be any fluid.
But we hardly put. What is the point is, I think the amount of dye that was.
Injection should be very big.
That should be very small. Exactly, you're right.
If you see in most
Yes.
Behind an air bubble.
more
Correct.
And it has to be behind an air bubble. You can't
single drop or two drops.
Yeah, I think that point is, that's the point.
See,
what we do is
what happened in this case is the amount of Trypan Blue I use is same for all cases, but this happens once in a year. So probably this is something else, but the message conveyed is do not go overboard with Trypan Blue just for the sake of, I think that's good enough for the audience.
Yeah.
Point taken, I think.
Thank you so much, Dr. Monica. Can we move on to the next one where we're talking about phaco in Fuchs? Dr. Srisha Kumar Kodur, he is a senior consultant at TAI Foundation in Coimbatore, and he's going to talk to us about it. Thank you, Dr. Srisha.
Good morning, friends on the dais and off the dais. So my talk is on phaco in Fuchs endothelial dystrophy. Though it's not very common, but you may find at least 1 in 100 of your cases, maybe a Fuchs case. So one should know what are the stages of Fuchs endothelial dystrophy. It is like you have 4 stages of Fuchs endothelial dystrophy. Stage 1 to stage 4. Stage 1 is without any symptoms. You will see central gut in both the eyes. The visual acuity is 6/6. And you have cataract, you can safely go ahead and do the cataract surgery with some precautions. Stage 2, stage 3, these are symptomatic patients, and stage 2 you have visual acuity loss. The patients will have mild symptoms of glare, halos, and the visual acuity can range from 6/6 parts to 6/24. And on examination you can see mild corneal edema and severe guttae. Stage 3, a moderate to severe loss of vision and pain, photophobia, watering, etc. and significant guttae and epithelial bullae. This is stage 3. These are the highly symptomatic patients, and the visual acuity can reduce to counting finger 3 meters. And stage 4 is a stage of scarring. Usually the patient will not have much symptoms in stage 4. So it's a scarred cornea. You can see subepithelial scar and very few bullae in the periphery or so. And there is a severe reduction in visual acuity, that is counting finger less than counting finger 3 meters. So you have to know the stage of Fuchs endothelial dystrophy. If you see here, this is a stage 1 Fuchs, and there are cells, but the number of cell count, it is reduced, and you have mild haze, but the patient is not very symptomatic. For cataract, he has come. This is a case of Fuchs endothelial dystrophy. You have to take adequate precautions in doing surgery in this case. You can see the guttae here in the center. So multiple guttae, which is restricted to the central 4 millimeters of area. And the surgery has to be done gently, and we have to inject visco liberally, and you even inject high molecular weight viscoelastic substance, and do a phacoemulsification, meticulous phacoemulsification. You divide the nucleus into as many fragments as possible, 7-8 fragments, so that you will not have a large fragment which can the other end of the the cataract fragment can hit the endothelium, and remove the emulsify these fragments gently and carefully, and see to it that your irrigation port, the sleeve, the hole in the sleeve is not directed towards the cornea, and do a cataract surgery mostly in the back or in the pupillary plane, and replace the chamber with the viscoelastic substance frequently, and irrigation aspiration also. The irrigation port has to be directed parallel to the iris plane. It should not be directed towards the endothelium, and remove all the viscoelastic substance from the antechamber in front, behind the IOL, and forming the chamber also. It should not be a too tight chamber. Even glaucoma, the increase in the pressure can cause damage to the endothelium. So this is how it is. This is a preoperative picture, and this is the postoperative picture. There's hardly any change in the endothelial cell morphology as well as the count. So this is a case of a grade 2, grade 3 Fuchs endothelial dystrophy. There's hardly any cells because of the edema. You are not able to freeze that particular frame. And these are the cases which require a combined procedure. Do a combined phacoemulsification and DSEK. First you do phacoemulsification and then strip off the endothelium. This is a Desmet scoring. I usually do Desmet scoring in Fuchs cases. It need not be done in all cases of pseudophakic bullous keratopathy. Only a chronic case of bullous keratopathy, I do scoring. Otherwise, we can just leave it. But in case of Fuchs, this is one indication wherein you have to score the endothelium, because there is thickening of the endothelium, and this is the desmetorexis. And you place your lenticule. I use a Sheets glide to introduce the lenticule into the antechamber, and then form the chamber, inject air bubble into the antechamber. Initially, at least for the first 20 minutes, it should be a tight chamber, and then you reduce the size of the bubble. So this is the postoperative picture, first day, and this is after 6 weeks. And this is the picture, that is the OCT picture of the patient. And so to conclude, whenever you are dealing with the case of Fuchs, with cataract. So if it is stage 1, if the patient is not symptomatic, you go ahead with the phaco and use high molecular weight viscosity agent. And of course, like you have to inform the patient that the condition can progress. You have to take an informed consent before the surgery itself, and the patient might require a DSEK or a DMEK at a later date. And stage 2, stage 3, you can go ahead and do a phaco. You can combine it with the DSEK or DMEK. And stage 4, where there is a subepithelial scar or a pan-corneal scar, in such cases you can either do a phaco with the DSEK or DMEK, or if it is a dense scar, then you have to go ahead with the penetrating keratoplasty. Thank you.
Thank you, Dr. Shisha. You made that Descemet stripping appear as if it was as simple as a CCC. So I wonder whether I should try it next.
Yeah, it's
I'm
easy actually.
on the lighter side, but I know it's not all that easy.
No,
Despite your efforts to convince me it's easy, I don't believe so.
Sir, it was so beautiful. How many have you done? It was just,
No, I have done around 300 cases.
Dr. Mallikarjun.
Can I add?
Yeah.
Yeah, I think wonderful thing. The few other extra points for the people who do only phaco and fuchs, we have done plenty, and we have a large series where actually we can get away with fuchs, only cataract surgery. Other few things which we have, there is something called tomographic edema, which is subclinical edema, which can easily identify on a pentacam, where a loss of isopax, the thinnest point is displaced beyond 1.5 mm, or there is a depression in the posterior elevation. These 3 points are very, because they won't have edema at all, but tomographically you can classify them, and if you can pick them up, and if there is a edema, then you have to go for, you have to be very careful and tell them that you may need a DMEK. And in cataract, few things which I do is I make sure, even though I'm a corneal surgeon, I do a scleral tunnel for all these cases because you want to protect as much endothelium as possible. And I also use BSS Plus, even though I use Centurion, I convert that case into a gravity and use BSS Plus. And really it works out well. Next day the cornea is crystal clear with all these precautions, and multiple viscoats coating at every level is important.
Yes, so there are symptomatic patients. The early morning blurring of vision, that is one of the first symptoms. Do you go ahead and do a combined procedure in those patients with early morning blurring?
No, they will have tomographic edema. They will also have subepithelial edema if you really look on any of the OCTs also. So those cases, and if they are symptomatic, absolutely no, because immediately you can pick them up in the first post-op day itself, the cornea won't clear up well.
Yeah, most of the patients, just phacoemulsification with all the precautions, they do well. Actually, the eye can sustain, the cornea can sustain for a very long duration. Even after phacoemulsification, they might require a DSEK or a DMEK at a later date, but usually 5-6 years they can wait till it becomes more symptomatic.
You can also look at the endothelium in the periphery. If the endothelium is good enough, you look at the cell counts in the center may not be good, but in the periphery you have a good counts. Usually those migration of the cells occurs much faster.
No, Dr. Rajesh, I have one question for you. Have you tried a DVEC?
Yes, that's what I was coming to actually. What you told, that migration doesn't happen like that. So I have a similar case, fuchs with cataract, did cataract surgery. Then what happens is subsequently this patient, both the patients, actually one patient had 6/12 vision and one had 6/18 vision after the cataract surgery. Everything was fine, but there was very thin, there's slight increase in thickness of the cornea. There was little bit of haze in the center. There were guttae in the center of the cornea. And the patient was still okay with that. A lady and both actually were ladies only. 2 cases I have done. So then in the center, there were prominent guttae. So I did DVEC and of a size of 4 millimeters. The idea is that you should take care of the whole of the pupil. So just did desmetorexis and left like that and kept the patient on
For the
rokinase, ROCK
non-cornea
inhibitors.
surgeons, DVEC is nothing but Desmet stripping without endothelial keratoplasty,
Yeah.
where we strip the endothelium and just leave it like that without transplantation of the endothelium.
And fortunately, both the patients are having 6/6 vision. What happens in these cases is that, if your peripheral endothelium is good, then the migration will be good if you just do stripping and then put the patient on ROCK inhibitors. I mean, it's a very small sample size. There's 2 patients I have done post-cataract surgery, DVEC. But it really has worked a lot in these 2 patients. So obviously, such patients you don't get very often. You have to do a proper case selection. That's why you can't have a very huge number in that. But then these 2 cases have encouraged me that yes, this is something that can be done and can have a good result. So
These patients will have.
How did you manage them in the immediate postoperative period?
There was a reduction in visual acuity. It went down from 618 to 636.
Yes, exactly.
Then the patient was on ROCK inhibitor. Gradually it improved, and now the patient, both the patients are having 6/6 vision actually, which is I was expecting an increase to maybe 6/9. Maybe the quality of vision will be good, but the patients had 6/6 vision. That was amazing for me as well.
What was your specular microscopic finding at the end of 3 months? Was there any size of the endothelial cells has increased significantly in the settle area?
See, this I don't exactly remember that what was the size of endothelial. Actually, I have the data. I wanted to report that, kept the data, but I haven't reviewed that actually. So both the patients' data I have, maybe it's somewhere in the laptop, and my residents had mailed it to me, but I could not review it actually. But I would love to do that. But yes, that is what is expected. That the size of the cells, there will be some. In the central part, there will be some, morphological, alteration. But still, if it covers up, then there is migration. Then clinically, the patients were absolutely fine. So all the investigations have been done, including the topography, including everything. In specular, ASOCT, everything has been done, and had very nicely shown the coverage in that area as well. So that I would love to review that, and maybe I will report it. So I guess clinically it works well.
Professor Rajesh, I think this.
Sorry?
You can combine the 2 in the same setting.
Yeah.
Yes, one can think of combining it only after having some more experience in that.
You can actually get a.
We are running out of time. Probably we should.
Just one observation. So since you said ROCK inhibitor, I had a patient who could not tolerate ROCK inhibitor.
Yeah.
So she had, otherwise she was very well controlled. I thought, in February 2020, Dr. Barun Nayak sir introduced it to the country formally. So I started her on that, and she just could not tolerate. She came to me with a lot of conjunctival chemosis, redness, and a lot of burning and itching, which normally subsides, but I had to discontinue.
What I have seen, your glaucoma people are using nitarsodil, right?
Yes.
Yeah, ripasodil probably has a slightly better response, but still you can have subepithelial edema, you can have congestion, you can have subepithelial, epithelial edema with congestion. Yeah.
I think we can use in all patients, instead of just
Thank you, Dr. Shisha. It was a very nice talk. Can we move on to the next one? Surgical strike and secondary angle closure by Dr. Mithun Pai. Dr. Mithun Pai is a senior consultant at Netradham Eye Hospital in Rajajinagar, Bangalore. Over to you, Dr. Mithun.
Well, my topic is in continuation with Dr. Monica. Basically, it's a surgical strike on acute rise in intraocular pressure during cataract surgery. The case being secondary angle closure glaucoma, more specifically phacomorphic glaucoma. As we all know, cataract surgery itself presents us with a lot of challenges in the form of mature cataract, hypermature brown and small pupils. Then there are the complications such as zonular dialysis and PCRs, which we tend to gain expertise over a period of years and tend to complete it in a span of, say, just 5 minutes. But significant number of cataract surgeries are associated with what is called, sometimes surgeons term it as severe positive pressure, that is raised intraocular pressure. Of course, Dr. Monica has spoken on the pre-op and post-op management, that is by oral acetazolamide, oral glycerol, or giving IV mannitol pre-operatively. But intraoperative raised intraocular pressure is a completely different challenge for the surgeon. Now, what are the cases which are predisposed to this kind of scenario? Mainly lens-induced glaucoma, in which phacomorphic glaucoma is a notorious one. Then any kind of angle closure glaucoma, be it primary or secondary, which have very shallow ACs. Also high hypermetropia and nanophthalmos can result in this kind of scenario. Unfortunately and sadly, even a normal case when taken can go up for this kind of scenario. For example, if the block doctor has given a block and not given enough pressure, you can face this kind of situation. Now, what is the clinical presentation of a severe positive pressure? The eyeball is extremely tense. It's also termed stony hard. Anterior chamber is not only shallow but extremely shallow and not responding to visco. Even if we put visco, it keeps coming out. And then there is the iris prolapse from a very well constructed wound. How do we manage such kind of situations intraoperatively? If rhexis is not done at all, then we have the option of postponing the surgery, put it on somebody else, or take it up on some other day when your luck is good. And if the rhexis is done, then we have no other option. We have to go ahead with the surgery. There are many surgeons who do many things. They try to loosen the speculum, they lower the BSS bottle. Many surgeons give intraoperative IV mannitol, waiting for about 30 minutes and then restart the surgery. But further management and outcome purely depends on the skill of the surgeon. When this complication occurs and anybody sees the surgeon, the skill of the surgeon is at display. You will know how good the surgeon is in handling this kind of scenario. But the final result, what we want, normal surgery with the intraocular in situ, is very, very rare. Every step is a struggle and every complication is possible. And what is possible? Starting from the initial step, there is iris prolapse from basically every wound. Then the iris viability is lost in a few minutes. There may be iridodialysis. Rhexis doing is almost impossible. It just goes away. Then nucleus delivery techniques all are very difficult, either SICS or phaco. There may be zonular dialysis. Then invariably, if it's a big nucleus, we'll strip the Decimet's membrane. But what is the eventual outcome? The usual final outcome will be a posterior capsular rent, which leads to a visual vitreous loss, and we do a vitrectomy. Now, this is the time where there is an actual decrease in the intraocular pressure, and then there is deepening of AC. At this point, if one is lucky, then everything goes on well, and if all the structures are there, we'll be able to put some sort of lens. But if your luck is bad on that day, either it can lead to a suprachoroidal hemorrhage or an expulsive hemorrhage. Few unique points about this scenario is, one thing is it's very rare. That is, it may occur once in 6 months or one in a year. So therefore, the surgeon is never comfortable handling this kind of situation, because all other complications he'll be handling very fast. There will always be a sinking feeling that, what you feel when you are a very junior surgeon, that something bad is going to happen next. Every possible complication mentioned in the textbooks can occur with this kind of scenario. All the structures from anterior to posterior are damaged. And unfortunately, vision pre-op is good in many of the patients. And post-op possibility of visual rehabilitation of such patients is severely compromised. Therefore, there is a need for a surgical strike in this kind of situation. A strike which reduces the intraocular pressure and deepens the AC. A strike which allows us to proceed with cataract surgery in the routine way what we are comfortable with. A strike which does not compromise with the integrity of the PC in any way. So what is that strike? This is the video. Sorry. Yeah, this is a case of phacomorphic glaucoma where we have taken up for surgery. We have done the side ports, but as soon as we do, there is a tense feeling. Whatever we do, even the visco is coming out rapidly, and even the iris starts coming out. we know that there is something wrong. Hence, we plan a surgical strike immediately, and this is that surgical strike. Basically, a 25 gauge trocar cannula is introduced transconjunctivally, and then the cannula itself is left in place. Here we have to use a vitrector. As soon as we put the cannula, there is egress of the vitreous through the cannula. Initially, vitrectomy can be done only at the hub of the cannula, need not go inside, but then we have to keep judging the deepening of the AC. If we are comfortable, then we try to start the case again. But during the surgery, if the anterior chamber again becomes shallow and tense and hard, then again we can repeat the vitrectomy as the cannula will be in place. Initially, it is a block of mindset, but then later it is quite easy to do. Again, at the hub we can do, or go deep inside and do a little bit of vitrectomy. And then once the AC is quite deepened, it behaves as a very normal surgery again. And then continue with the way we want to complete the surgery. Advantages of this kind of surgical strike: there is a very slow posterior displacement of the lens. We wouldn't want a PCR to occur, then a vitrectomy, then this kind of scenario. And vitrectomy can be done multiple times through the cannula. There are other methods where surgeons practice. One is vitreous tap with needle aspiration. A greater chance of hemorrhage is there. Also pars plana vitrectomy, which is quite popular, but it needs a little bit of expertise. Of course, even with this procedure, risk of expulsive hemorrhage remains. So one has to gain little bit of expertise in this also. And finally, thank you. Thank you to my teachers, Dr. Sirish and Dr. Malik, and to my colleagues who have helped me in this presentation.
Thank you so much, Dr. Mithun. Indeed, it was a very nice one. Dr. Mithun had come to the conference for an emergency. He had to flow out to Bangalore and then come back again only for this talk. And I am sure it was worth every minute of what he spoke. He made that long travel. Thank you so much for that.
So this complications happens not always, but once in a while it happens. So patients, older patients, those are atherosclerosis, and all those patients are more prone for this. And loose journals, as I mentioned, loose journals, and when you do hydro, the fluid escapes into the anterior vitreous. Identifying it as early as possible is very important. But sometimes you don't have to do a vitrectomy. You just, if you don't have trocar and all, you just put a needle there. Measure 3 millimeters. Put needle, just aspirate. You should be just below the lens, and just aspirate some fluid. You don't have to. That itself can deepen it. And if yes, it works.
As he has explained, the chance of retinal post-operative retinal detachment is higher because you are pulling the vitreous.
Yeah.
But I think the process which he has shown is probably better.
This is better.
Will it be easier to use a valve trocar and do a whole vitrectomy, even not letting the vitreous to come out and cutting? So in that case, chance of pulling.
Yes, sir, definitely, definitely.
And
this is a non-valved one.
Direction of the cutter has to
be very important.
Has to be directed posteriorly rather than any angle.
No, sometimes what happens, the standalone surgeon, those who don't have a vitreous VR surgeon support, they can, I think that's such a, either if it is very severe and you are not able to do anything, just close all the wounds, leave for 1 or 2 days, it might settle down.
It has happened to me once.
Which one?
25 gauge, sir. 25 gauge. If you have to.
It has happened to me when I'm doing the Rexis, and the shallowing of this, you can't even bring the forceps out.
Yes.
It's almost touching them.
It is now routinely happening even in normal NS2, sir, in cam setup. Earlier, our seniors used to call us and blast us. Why you have not given massage properly? Now we have stopped.
Now you are learned yourself, okay.
Now we have stopped.
I think keeping a trocar cannula in your clinic is not very expensive, and this is really a very nice demonstration, I would say, much better than, anything else.
It can be done even with anterior and vitrectomy cutter.
Yeah.
Did you use IV
Yeah, we have used, but the pressure was a little high only, but we had no choice. We had to go with the surgery.
And was it case of phacomatous glaucoma?
Yes.
Did you plan a combined surgery?
But that
I
patient,
will always go. I'm sorry. I will always go.
no, patient was very frail, madam. Patient was quite frail. We didn't want to.
All of them are frail. By the time they get phacomatous glaucoma,
Yeah.
they are all frail.
How long the glaucoma has been there? Right?
Pressure is above
Yeah,
50.
it was.
The pus will only develop only after a certain duration.
Yes, phacomatous
We have a study of neglected 50 eyes with phacomatous glaucoma during pandemic. 1 month sitting at home. So I used to say, just PR. I used to say that this also may get knocked out if I do the surgery. Used to get luckily, all of them got 6/6 vision. So somebody was I cannot. It's not my surgery. It's something really,
No,
really
usually
bad.
phacolytic or phacomorphic, usually tackling the cataract usually sorts the issue. Unless you have a documented proof it's been staying for a very long time, which is unlikely in especially these two
We
conditions.
had those OPD slips from primary health centers of 21 days. They said we thought your institute is closed. So these were the study of over 21 days.
But they had a pressure rise over this whole period. You had
See, initially in the primary health center, they wrote digitally hard. They gave Diamox, they took for 2 days, stayed at home. And then they said we didn't have, all kinds, this lockdown.
Probably the pressure came down, they didn't have pain, that's why they
The
didn't-
pressure was 50 plus when they came to me. With this glaucoma. They were very strong.
so many times even if they have very high pressure, they don't come pain. So they
56 pressure.
Yeah, I think shall we go with the next talk because we may lose
short
time.
of time.
This has been a very nice session, sir. Thank you to all of you. Really nice.
The main, I think, take-home message is you need to know what is the right thing to do at the right time. So right decision at the right time saves a lot of trouble.
It has to be
So
case-based, that's
yeah.
the-
Can you invite Dr. Sudhakar?
Dr. Sudhakar Putti he heads the Shankaraya Hospital at Guntur, and he is also a very good corneal and cataract surgeon. And he would talk on cataract with iris cyst, the case which he managed.
Thank you, sir. Thank you, AFC, for the opportunity. So, cataract with iris cyst is my topic. So, why do iris implantation cysts occur? These are much more common than the primary cysts, which are congenital, but these are secondary due to trauma, and the causes would be delayed wound closure, inadequate wound apposition during the closure, postoperative ocular hypotony, which will undo your appositional work during the closure, incarceration of iris into the wound for long enough. So though they may not be Siedel's positive, but there will be a tract that will form, giving the access to the anterior chamber of the corneal epithelium. And of course, wound dehiscence, which is also ocular hypotony and causing migration of the epithelium. So why do we need to manage these irises? Because epithelial ingrowth into the angles can cause intractable glaucoma. The mass effect can obviously obscure the visual axis. It can also cause secondary angle closure.
All cases are nice.
The UBM is the gold standard to look for the extent and margins, but not many people have it. A lot of people do Ascot as a substitute, but shadowing by the pigment epithelial cells do not allow for the posterior delineation and the exact extent of the cyst. So management, wide excision is reported widely, but because of the inadequate availability of UBM, so the actual extent is often missed, and therefore some part of the cyst tends to remain, and that will cause recurrence. Even wider excision would obviously will be complex and destructive because you're going to remove wide areas of the iris. Recurrences are also reported. Lasers and diathermy also have been reported, but I don't have any experience. Of late, cyst aspiration with ethanol irrigation is being practiced. And this is an easy procedure that can be practiced by anybody, and the reagents are always available in your theater, and it can be repeated also safely in case of recurrence is there. So we performed cataract surgery with cyst aspiration and then alcohol devitalization of the cyst wall. And we actually also removed the cyst wall. We didn't want that some remains. And even if some part of the cyst wall remains, because it is already devitalized by the alcohol, the chance of recurrence is very less. Excuse me, videos. Yeah. Sound.
In 2016, a young male comes with complaints of pain and photophobia in the left eye with a history of corneal tear repair many years ago. On slit lamp examination, he had a traumatic iris epithelial inclusion cyst with early posterior subcapsular cataract and a vision of 6/18. The ultrasound biomicroscopy showed an iris cyst, but the tract communicating with the corneal tear could not be made out. The cyst was occupying 1/3 to half of the anterior chamber and was limited to iris. As the intraocular pressure was normal, the patient was managed conservatively. For this patient, we had two options. First is penetrating keratoplasty to ensure complete tract removal, along with cataract surgery and cyst removal. Second is plain cataract surgery with cyst removal and to tackle the recurrence when it occurs. Just like the saying, let us cross that bridge when we come to it. Few years later, during the pandemic, patient comes with mature cataract. Due to unavailability of corneal donor tissues, we have decided to go ahead with plain cataract surgery and cyst removal. Here corneal incision was made and air, blue, viscoelastic was injected into the anterior chamber. Two side port entries were done. The iris cyst was separated from the anterior lens capsule. Capsular excess has been done. Gentle phacoemulsification of the nucleus was performed. Followed by implantation of foldable intraocular lens in the back. To tackle the iris cyst, a three-way cannula has been used, first to aspirate the contents of the cyst. And then to inject absolute alcohol, which was retained in the cyst for 30 seconds. And the cycle with absolute alcohol was repeated to devitalize the epithelial cells. The devitalized cyst wall is then peeled off and removed. Immediate post-op showed clear cornea with no remnants of cyst, and 1 month post-op the vision was 6/9. And there is no evidence of recurrence.
Thank you.
Dr. Sudhakar, it's a very nice video. Only one point I want to add up in all these cases is the primary wound repair, whoever is doing, they should take care of the wound repair. If they have done these implantations to not have occurred.
Yes, sir.
We have seen a lot of children who had the wound repairs, they come back with iris cyst later, and all these are going to be a complex problems. Yeah. So I think we need to stress on the primary wound repair proper work.
Unfortunately, wound repairs, cataracts are done by senior faculty. That is our fault. In our institution, the person on emergency duty is PG and senior resident. So unfortunately, all the jagged, bottle cut, and compass going, they're all done.
They're
by
doing the repairs.
We should take care of that.
I have a question.
Yes.
You are using absolute alcohol, that means 100% alcohol.
Yes, sir.
And you are injecting, and we can see that it's also flowing.
The cyst wall is ruptured in this case. Yes.
So is it not going to cause any damage to the
You have to fill the anterior chamber with viscoelastic. So the minute the cyst ruptures, it is visible, like the tract. And you immediately, because your side ports are there, you immediately go in and aspirate with visco.
You give it a wash after that with the saline?
Yeah, because the visco is removed, the alcohol is removed with the normal bimanual irrigation aspiration. No.
Wash the cavity again and again.
So if the cyst doesn't rupture, this is an edited video. The cyst ruptured because of the manipulation and the second cycle of the alcohol. So you can, if you, with Helon, if you know, Helon or sodium halonate, cohesive viscoelastic, so even if a little alcohol does leak, it is contained by the tightened chamber. So it is not an issue. The part obscured by the cyst, I could not have access. So whatever I could see is a semi-rhexis. Behind, I don't know what it is.
You could have done the iris cyst first and then go ahead with the cataract surgery.
Could have done. Both ways were possible. Yes.
Suppose you had left it untouched
Yes.
and just done the cataract surgery there.
Yes.
And followed up later to see if there's any problem.
I could. I was doing, it was already 1/3, the cyst was there and it ruptured during the manipulation.
Actually, we should not do that, because what happens is the cyst enlarges and it comes in the visual axis, and that will cause more damage to the cornea.
Yes. It's already
so
touching
cyst
endothelium.
should be removed, and I think it can be very easily separated from the cornea by peeling it, and then you inject some viscoat kind of a thing, chondroitin sulfate, in between the cyst and the cornea, so that you separate it. Once you have completely separated, then whatever you want to do, you can do a cataract surgery first, you can do a cyst removal first, whatever. But cyst should be removed, and sometimes you're not able to remove the posterior wall, but at least the whole of anterior wall should be cut with the vitrector, and it should be removed.
So that will devitalize the remaining cyst wall. So that was the benefit of it.
I will be a bit hesitant in using alcohol, but then I don't have a personal experience, so I will not be able to comment on that. But
a lot of cases have been reported with this.
Yeah, there are reports.
We are following this patient, but you will not have a large sample size.
Yeah, there will be a confounding effect also because of the presence of the cyst already damaged the endothelium that has happened. So that's the reason.
Yeah.
I think we should.
Anyway, I think the patient is concerned for penetrating keratoplasty, so you can safely go ahead. So we are running short of time.
Thank you,
We
sir.
have 2 more talks to go. So now I call upon Dr. Sirish Nelvigi. He is a solo practitioner, an excellent glaucoma surgeon, excellent phaco-surgeon. He is going to talk on audacity of a laxity. I don't know what it is.
Laxity is a zonular laxity, so how audacious they can be.
Okay.
So I am talking about 2 scenarios, where scenario 1 where you know that the subluxation and zonular laxity, oh, it's not running there, sorry. It's running here for me.
Audio
Let's project it here, please.
Anybody from audio?
Yeah. Okay. So it is about zonular laxity and how audacious they can be. I'm talking about 2 different scenarios. Scenario number 1, where the zonular laxity is already pre-known, and before you start your surgery, you know that there is laxity of the zonules. Obviously, I'm talking about a scenario where this is along with glaucoma. So this makes the challenges difficult. Here in this scenario, of course, decision 1 will be whether, if it is a long-standing chronic glaucoma, whether you want to add up glaucoma surgery on top of having challenges of doing a cataract surgery here or not. So you tend to be a bit more conservative in such situations. Obviously, the challenges of cataract surgery here will be itself quite a lot, and you would have to take care about how you make sure you need to get as big a rhexis as possible, whatever is reasonably allowed, and then CTR, if laxity is less than about 180 degree, you can do it. But as you see here, as you are placing the zonule itself, it can tear a little bit more zonules than what were there before. So in additional support, you can always place iris hooks. With you can do it, just the CTR alone may not always be sufficient, because if you give a good traction on the other side, you'll be able to hang on to the bang much more easy. So here you always have a threat where you can end up hydrating the vitreous, and in the scenario of a glaucoma where you are hydrating the vitreous, it's going to be an even bigger difficulty, and such situations you may have more challenges coming up for you. When you are placing the intraocular lens, make sure you use one of the haptics have to be placed along the area where the zonular laxity has happened. This is how it is positioned there. and then after that the decision, if you, this is scenario number 2, where actually the trabeculectomy was started, but then when the rhexis was initiated, it was observed that there was a gross amount of zonular subluxation. So this was not known prior to the surgery. Since it was a brown cataract and a small pupil, and the amount of tilting of the nucleus was very, very huge, a conversion had to be done. So this was converted into a SICS, and it was observed that since the laxity of zonules was very severe, there was no practical way that phacoemulsification could be done. A large extension was done, and the nucleus was fished out. So here the priority will be to just make sure you don't have a drop and complicate your process further and make it a triple trouble. The question here is, would you want to go ahead with a trabeculectomy in such a scenario? The answer is yes, but there are challenges involved. Once you have a scenario like this, you have the vitreous which comes. Unless you do a very, very good vitrectomy, you have situations where you might end up with vitreous inside the ostium, which can actually negate the whole effort that you have been doing. And actually, you do need trabeculectomy happening here all the more. Though this was a pre-existing glaucoma patient and you wanted the glaucoma surgery for the raised IOP, but then when you have complications like this, you have another added risk factor, which is so increased inflammation and vitreous there, which can again increase the further risk of additional risk factors for glaucoma. So it is advisable that you go ahead with a trabeculectomy, though the chances of blockage can again be pretty high. As long as you make sure that the vitrectomy is done properly, and then maintain the post-operative status well, control the inflammation well, again, you can reduce the risk factors of further elevation of intraocular pressure in such scenarios. If you take care of the right situations, pre-operative, intraoperative, and post-operative, you should be able to handle quite a lot of iatrogenic glaucomas and drug-induced glaucomas, inflammation-involved glaucomas, which can actually potentiate the complications during the surgery and before the surgery and after the surgery. Thank you so much.
Thank you, Dr. Sirish. So it's a wonderful demonstration of your surgical skills. The first case, I would have done it slightly differently. That is a case of subluxation where you could see the vitreous was protruding, no? Like could have injected this thing, IV, triamcinolone, and done a vitrectomy, and then you would have gone ahead with the capsulorhexis and capsular support with the capsule hooks. And you could have waited for some more time till you finish your case. If the bag is stable, you could have injected your CTR a little later. So I would have done that way. Dr. Santosh, what is your technique in this particular case?
I would also have done vitrectomy first, but otherwise it is just the same iris claw lens with this. Regarding trabeculectomy, the decision making has to be judicious, probably. Same setting trabeculectomy, or maybe you observe post-operatively how the patient behaves and then decide about trabeculectomy. What do you feel, Dr. Rajesh, about trabeculectomy in such situations?
Yeah, actually, that's what I was telling. That in all these cases, wherever you are in a borderline situation and you are thinking that by removal of lens only, if we can have some reasonable control of intraocular pressure, maybe we can see in the post-op period we can.
Because that surgery we can always do in a subsequent stage. If we can manage pressures by using medicines, which are very good medicines are available, it's better to manage them medically rather than directly jumping to surgery. Because if there is also a chance of failure of trabeculectomies on long-term basis after 5 or 7 years down the line. So I don't know, it's a point for thinking.
In the first case, the trab was actually, the trab was not planned, it was a glaucoma surgery. In the second case, the trab was planned.
You made a flap
In the first case, you had done the flap and then started.
Planned there. It was a glaucoma
It was a plan,
case with,
you had planned it, so you did it, correct.
So, ultimately, in the first scenario, that is what eventually happened. We managed the glaucoma on a long term on medications. In the second case, the intraocular pressure was fairly okay when it was managed fine. But then again, when we have trabeculectomies done even like this during the course of surgery in the first sitting itself, the chance of failure of trabeculectomy is generally much higher than a routine trabeculectomy. So there are possibilities of, again, a retrab which may be necessitated over a period of time.
So is it better to delay trabeculectomy as a...
I think once we have, when you have done the flap, I think you have done most of the work there. Ostium is done. And moreover, when you do an incision as big as that, which is like SICS, that itself works like a wick there. And that itself is a big trabeculectomy. Which
I guess it's the scenario based.
Just making a punch of another 1 mm larger punch there actually doesn't make too much of a difference. If you
you have to decide as per the scenario at that time.
Thank you, Dr. Sirish.
Actually, one acknowledgement here, the videos are, I thank Dr. Krishna Prasad for the videos actually.
Thank you, Dr. Sirish. So we have one more talk to go. Dr. Anant D. Dr. Anant, he is a senior cataract and refractive surgeon at Lotus Eye Hospital, Coimbatore. He is going to talk on dry eyes and cataract surgery.
So, good morning everyone, and thank you Sirish sir for including me in this topic. After listening to all surgical challenging cases, it's a cold case, medical case each and every day. All these cases you will see once in a week, but my topic, each and every patient, either you may be exaggerating the dry eye or you may be forgetting about the dry eye and doing the cataract surgery. So, we do perform the cataract surgery very successfully, but if at all, if dry eye is forgotten or if it is neglected or if it's exaggerated, the quality of life is affected to the patient keeps coming repeatedly to us, it can have a double-edged effect affecting our name and the hospital brand also. So we know dry eye is a chronic disease. It's much more prevalent in the age group between 50 to 70. Females do suffer more. And as I mentioned, cataract surgery can be iatrogenic also. It can exaggerate also. We can see the significant reduction in Simmers, T-BUT, and tear meniscal height. Even in non-dry eye group also, dry eye symptoms do appear. The triad of dry eye, the tear film instability, hyperosmolarity, and inflammatory mediators, release of cytokines, interleukins, stays. The end target is the apoptotic death of the surface cells. And added to this, cataract patients can have physiological decrease in the tear film. When this topic was given to me by Dr. Sirish Kumar in my busy schedule, I thought I should speak on cataract surgery induced dry eye. But after looking to the program book only, I understood that I have to speak on the topic where I have to do cataract in a dry eye patient. So I had to change my topic just 3 days back. This same thing happens whenever we are handling the cataract surgery patients also. We are paying attention to his reduced vision, planning about the type of surgery, type of IOL, but we tend to forget these symptoms. Each and every symptom has to be paid attention, whatever busy we are. Otherwise, we are going to suffer or we are make the patient suffer. As such, dry eye has got a huge impact on the cataract surgery. First, coming to optical biometry, you need to have a stable tear film. It is known that if the tear film is not stable, it is almost going to affect the keratometry value by 1.3, which has a significant effect on biometry and our IOL calculations. In our institution, we do invasive, non-invasive, both T-BUT before cataract surgery, because majority of the patients are premium IOL patients. And it is also documented that hyperosmolarity, when it increases, normal is 304 to 308, it increases, it has got a significant values on keratometric values. And we never want a patient to have a fluctuating vision in a premium IOL sector patients, either trifocal or multifocal patients. Dry eye induced aberrations can bring about fluctuating vision, so we need to stabilize the tear film and then go ahead with the cataract surgery. Evaluation, the basic questionnaire you should have, invasive or non-invasive T-BUT test is mandatory. If in doubt, please stain and Simmers test is mandatory before. This chart alone explains each and every modification which we need to have in our own practice. Preoperatively, we might have seen sisters are not aware. We need to educate them about the precocious use of anesthetics. Sometimes we are doing topical surgery, patient not cooperative. The tendency is to put 4 or 5 drops of topical anesthesia. We need to make sure that not more than 1 or 2 drops. Sometimes mydriatics do induce blepharitis and bring about surface inflammation also. BAK, even 0.001% can bring about epithelial toxicity. Intraoperatively, short surgical time is always better. Long surgical time, phototoxicity, release of interleukins, it can bring about the damage. We are putting a speculum. There can be a tear deficiency. The pupil is dilated. The defense mechanism of blinking and meiosis are not there. So this has to be taken care, quick surgery. And the corneal incision usually doesn't matter, superior or temporal. And most of the times we are doing the temporal phaco of 2.8. The transaction which happens is very, very minimal. But whenever we land up in an eventful surgery or extending the wound or you are hydrating too much, there can be anesthesia of the stromal plexus of nerves where you have done the transaction. And it almost takes around 1 month for the nerve to regenerate. Lid speculum, again, it can express the mucobabin glands. There can be alteration of congruity of the dynamics between the lid and ocular surface that can alter the tear film. Post-operatively, preserved antibiotic for a long time can bring about the surface damage. Antibiotic should be restricted only for 5 days. Some NSAIDs do bring about epithelial toxicity. So how to avoid, as I told, educate the sisters to use anesthesia only once or twice prior to surgery. And intracameral adrenaline, we have this fusion, it can be used and shorten the surgical time. And these days, we are doing more number of femto cataracts. Femto, whenever we are placing a femto ring, it's a scleral-based ring. That itself can bring about a global cell damage, conjunctival hyperemia, inflammatory edema can be there. So we should be precautious while doing femto-based cataract surgery in already patient having a dry eye. And one more important thing is persistent surface irrigation has to be prevented, so we can put viscoelastic devices over the cornea and continue with our surgeries. And antibiotic should be limited only to 5 days, precautious use of NSAIDs. Coming on to the, and we should also pay attention to the associated comorbidities, patients, hypertensives, diabetic, autoimmune people, Parkinsonism, we are on multiple systemic drug, we can exaggerate the dry eye in these patients. Diabetic patient, diabetic capital is our country, so we need to understand that diabetic patients are more prone to suffer from dry eye. Lifestyle modification has to be advised to the patients. This has to be kept in mind. And each and every cataract surgeon is a master in handling the dry eye patients because we need to get away with the patients because of these complaints. Multiple drugs are available, but in my personal choice, I would like to use CMC 0.5 or 1% for all the patients who have exaggerated dry eye symptoms. Thank you.
Thank you, Anant. It was wonderful. It's a comprehensive coverage of the topic. We do a dry eye workup for almost all the cases of cataract and refractive surgery patients. Dr. Rajesh, do you do it routinely for all your cases?
Not the whole of, not 100% of cases. But if, in refractive, yes, 100% of cases. But when we are doing cataract surgery, we see if the patient, we have to be, we are a little selective in that, not in all cases. If the patient has any of the symptoms, if the lid margin showing some MGD, etc., if there is some degree of, subtle surface inflammation, or the patient has some complaints. Some patients do complain that, the patient has less vision but still complains that I'm having watering, I'm having itching. So those patients do require the detailed investigation. But there are some patients whose ocular surface is absolutely clean, shining, everything good. Patient has complaints of blurring of vision, only has a cataract which is commensurate with that. Then in that case, we don't do.
Dr. Shiris, I think one simple thing which we do is we do what is called ocular surface stress test. cyst.
Okay.
At the end of the day, when the patient goes through all the procedures, contact, non-contact, topical dilatation drops, and when they come and if you see any staining on the cornea, that means these patients are prone for not the 80 mark, but the surface staining. That is the patient where we need to take extra precaution.
One question to you, Dr. Sudhir. Like if the patient comes for a workup for cataract surgery and you detect severe dryness, that is Schirmer's 0, 1 and T-But also like 1 or 2, and your lipid layer thickness is also less, around 30 nanometers. So in such cases, like how long you will wait? You will treat them immediately, or how is it?
No, we have to treat them. I think these patients will do well with cautery, the punctal cautery, or for plugs. At least give a trial of plugs and see how they do well. And maybe these are severe patients, may need a cauterization of the puncta.
But
and once you have the...
With that, you go ahead and do the surgery immediately, or
not
you will
immediately.
wait for some time?
Wait for some time on the surface.
How long you will wait? Or
Usually
you
2-3
want to
minimum.
Improve the surface?
Yes. Because your DBR, everything will change. So you have to wait until the... Yeah.
Any comment on lipid flow?
Do you take the hair pop? I mean, do you rule out all the systemic diseases?
Yes, sir. Yes, sir. The severe dry eye, we do the entire workup. Even the rheumatologist workup is very important in these cases. And then we have to wait them for at least a month. Once it stabilizes, then go ahead with the surgery.
Thank you. We have come to the end of the session, and I thank all my co-panelists, all the speakers, and all the audience for their wonderful participation. Thank you very much.
Thank you so much.
Thank you.
This is a very good session.
Nice. Yeah, good. Yeah, I think we'll take.
I agree.